Introduce himself. So we're trying to speed this up, although I'll tell Pete, we've got 5 in this group. It's going to be really hard to stay on time.
Do our best. We'll do our best to stay on time here. So we're gonna kind of shift gears here, and I'm gonna run through some of the clinical trials for cryptococcosis that have been done, and really sort of focus on sort of recent things that are unpublished, current ongoing trials, and sort of near future trials that are funded and are actually going to happen. So some disclosures from some people in the room here that we collaborate with. And so the recent stuff, really unpublished things. And so basically kind of to highlight, so basically one slide and you can fall asleep, I guess, or go to the bathroom. So basically at sort of the 4 sort of agents that have been looked at that have been presented in the last year or so. One was looking at high-dose fluconazole. The punchline was, as you went up to 2 grams a day of fluconazole, it was better than the 800 milligrams or 1,200 milligrams, but it still was not better than amphotericin. The second is our team in Uganda has been working on sertraline, and basically it did not affect survival in a phase 3 trial. Also looking at sertraline plus fluconazole in a small phase 2 in Tanzania, had better fungal clearance, and in a RCT for asymptomatic cryptococcal antigenemia was halted due to SAEs. And then lastly, tamoxifen as another synergistic agent was basically didn't show any effect. And so I'm going to run through some of these trials in a little bit more detail, but that's the punchline. So of these, the first one was the ACTG HIFLAC trial. Basically, the purpose was to look at higher dose fluconazole, 1,600 milligrams up to 2,000 milligrams a day for through 10 weeks, and basically standard sort of endpoints and outcomes looking at change in CSF cultures, looking at toxicity, and looking at survival. And so this was presented at CROI. Rarely have I seen a abstract presentation being shouted down as unethical, but this one was. It was very sort of contentious. And so basically what happened was, as expected, the fluconazole arms were not as good as amphotericin. And so the ethical argument was, how can you randomize someone to fluconazole in a setting where you have ampho available? So basically the lines sort of match up there, and the worst survival was the 1,200 milligrams of fluconazole. That arm was closed early, and then looking at the purple line with 1,600 milligrams and 2 grams a day, basically still had higher mortality rates than the ampho arms. When they looked at progression of symptoms, and so part of this trial is if they progress symptoms, they could be switched to amphotericin therapy. And so when you look at the rates of progression of symptoms, so basically death, recurrent meningitis, or sort of progressive symptoms, a lot of sort of progressive symptoms in people being switched to amphotericin as well. So that was sort of the fluconazole data. So we presented at CROI in March. Josh Ryan, who's in the audience, presented for our team at CROI our phase 3 trial. And so as some of you may be aware that in vitro and in vivo in a mouse model that sertraline had synergistic activity with fluconazole. And so basically in mouse brain, it reduced the fungal burden. And so it had a mechanism of action of basically interfering with protein translation. And it was also active against the planktonic phase, so the quiescent resting phase of yeast, where azoles are typically not active against that phase. So in vitro, in vivo data looks promising, but so what we found, so a couple things here, I guess. This is basically, the trial was run over 26 months, so a little over 2 years. So in that time period, we LP'd 800 some patients, of whom about half of them were enrolled into the trial. And so these are first episode cryptococcal meningitis. So the burden of crypto certainly has not gone away. In our experience in Uganda, the number of patients has increased over the last decade, even though antiretroviral therapy is available. And so unlike prior trials, about half the patients are AOT experienced, and so these patients are coming in to the trial already on antiretroviral therapy, and they basically have virologic failure. And so in an abstract that we're submitting to CROI for this year, they actually are taking their medicines, at least at time of coming into the hospital, but they do have virologic failure. So it's not that they're just not taking the medicines, they actually are taking them, but unfortunately not working for them. And so basically overall in this study, it was stopped for futility at the third DSMB, and we were about 75% of the way enrolled, and basically, as you can see, there was basically no difference in the mortality over the first 2 weeks. The curve sort of slightly diverged thereafter, but basically no statistical difference, and basically there's about a 50% mortality rate over 18 weeks. And among the ART-naive population, as well as the ART-experienced population, similar outcomes. So how this trial was run was we did a higher dose. So sertraline is Zoloft. I should probably maybe back up and explain that. So Zoloft is a common SSRI antidepressant. It's the most commonly prescribed antidepressant in the US. And so we'd increased the dose to account for potential induction of metabolism by antiretroviral therapy, and used 400 milligrams for the first 2 weeks, and then used the 200 milligram sort of max standard dose normally over a 16-week period. And so basically during the higher dose time period, there was no difference whatsoever in outcomes. So efavirenz, which is a common NNRTI, as well as nevirapine and other protease inhibitors, basically do induce metabolism of sertraline, and so the levels were about 40% lower than people who were ART naive, which has the implication of that if we're using SSRIs in our patient populations, that at just the normal dosing, that's also metabolized lower, and so probably the max sort of dose that we normally think about in SSRIs isn't really the case when you do the drug-drug interactions. So basically, our conclusions from the study is it had no effect on mortality, and so I think William Hope's going to talk a little bit more about this, that in this study we're using basically amphotericin plus fluconazole backbone plus the third sort of study drug. And so why didn't this work? It worked in mice, it worked in Petri dish. Why doesn't this work? And so part of it may be inadequate drug concentrations in the central nervous system. And so in this case, it took about a week to achieve steady state, the sort of therapeutic levels in brain tissue. And then we basically ran the high dose for 2 weeks, which really meant they had basically therapeutic drug levels in the brain for maybe a week while they're on amphotericin. And then we had dropped the dose to 200 milligrams due to the known safety profile of that, which in retrospect was probably not a very good decision. And so basically, we think we didn't really give sort of active enough drug levels in the brain for long enough. Also, the issue of drug-drug interactions, as we, after the study, achieved sort of more data on that, on the effect of drug metabolism. So another study, this is a phase 2 study that's been submitted for publication and keeps getting rejected. Basically was presented at CROI in 2017. It was a pilot prior to sort of trying to get Tanzania on board for the phase 3 trial. And basically with sertraline plus fluconazole, we had sort of 28 patients, and then eventually were allowed to import amphotericin into the country and used a short course of amphotericin along with fluconazole and sertraline. And so with this, basically the survival rates were not particularly good with the sertraline fluconazole arm. It was about 64%, which isn't very much different than fluconazole alone. But with sertraline fluconazole plus amphotericin, the 2-week survival was almost 90%, which is in Tanzania, this is a very resource-limited area, and the EFA was 0.48, so that's actually fairly good, and basically is about 50% better than sort of the historical published literature on rate of clearance. And so that sort of seems promising. And so we did move forward with a sort of cryptococcal antigen screening study. And so this is taking asymptomatic patients. The standard of care for asymptomatic cryptococcal antigenemia is fluconazole monotherapy. And so we basically randomized people to get standard therapy with fluconazole, or we basically gave them fluconazole plus sertraline, so banking on some synergy. And so basically we slowly ramped up the sertraline over 4 weeks, and then they were going to get sertraline for basically 3 months, and then sort of taper it off over a month. And so that was our study design. We enrolled 22 subjects, and at the time of our first DSMB, the trial halted enrollment. And so in the sertraline arm, there were 3 episodes of sort of mania, altered behavior, which we see in people with cryptococcal meningitis about 10% of the time. 2 of those patients weren't taking their medicine, and so question of was it the sertraline or withdrawal from the sertraline, or was it just crypto progression in their brain? And then one person that did have good medication adherence had a probable serotonin syndrome, and but even after we stopped the drug, they had sort of ongoing psychosis sort of issues, which sort of persist 6 months later, and so that person may just have sort of psychiatric illness issues and unrelated to the sertraline. So of the primary endpoint for the study, of the 22 patients randomized, in the standard of care arm with placebo, there were basically two endpoints, one death and one meningitis. In the sertraline arm, there were no cases of meningitis or death, but there were these SAEs, and so the DSMB had stopped the trial. So what to make of this study, I'm not sure, but for us, we're sort of moving on from our sertraline days. And so sertraline, one of the things that we really liked about it is it's a commonly prescribed medicine. There's a massive safety track record. It's cheap, so it's like 5 cents a tablet in the US. Nothing is cheap in the US, but even this is cheap in the US. And there are 23 manufacturers around the world, and it's something you can find in any pharmacy around the world, even in Uganda. And so it was commercially available. And so drug access is an issue. So drugs like 5-FC, which are not available, is problematic. So we're moving on from this. So next sort of drug that's sort of new or novel, or once again repurposing existing drugs, is tamoxifen. So it's the breast cancer treatment is a selective estrogen receptor modulator. Once again, it's highly bioavailability, widely available worldwide. It's safe, decades of experience, and once again, it's off patent and it's fairly inexpensive. Has some anti-yeast activity in vitro against Saccharomyces, Candida, and Cryptococcus, and so has been looked at. And so Damien Christian, who used to be at Rochester, is now at the University of Iowa, has sort of worked through some of the mechanism issues. And so basically there's a mechanism, it binds to calmodulin, and it's basically is synergistic with amphotericin. And so once again, synergy with existing medicines. Sounds very appealing, active in a mouse, active in vitro. And so has, among a number of different clinical isolates, has some fairly good synergy and positive interactions and no antagonism noted. And so in this study was basically a phase 2 open label study looking at what the rate of clearance. And so for cryptococcal trials, looking at sort of the rate of CSF clearance of the yeast is generally sort of on a linear scale. And so this basically was a randomized study. And so basically the word that was presented sort of informally at a Woods Hole meeting this summer, and basically there was no effect on the early fungicidal activity, so on this rate of clearance. And that was once again in the setting of an amphotericin and fluconazole backbone, so this would have been the third drug. So that's sort of what's sort of recent trials which have been, I guess, profoundly unsuccessful. But there is some ongoing, at least one ongoing trial that's enrolling. And so this is the Ambition study led by Joe Jarvis and Tom Harrison. And so this is looking at basically single-dose liposomal ampho, so ambisome, at 10 milligrams per kilo, just given once. And so basically you load up people with the liposomal ampho, and it basically has a long half-life in tissue. And so some really elegant animal model work that William Hope has done basically has demonstrated that this is as good or better basically pharmacokinetic delivery than our traditional 14 days of amphotericin. And so this trial design is basically this one-time dose of liposomal ampho with fluconazole and flucytosine backbone as oral therapy versus the standard amphotericin deoxycholate given with 5-FC for 7 days. And so that basically builds upon the ACTA trial where fluconazole 5-FC was non-inferior to amphotericin therapy, and 7 days of amphotericin was as good as 14 days in this ACTA trial that Tom Harrison's group had performed previously. So with this, in a phase 2 trial, they basically looked at various dosing schemes. And so they looked at a one-time dose, they looked at repeating it for 2 doses or giving 3 doses. So a 10 milligram per kilo followed by 5 milligram per kilo or 5 milligram per kilo versus the standard 14 days of amphotericin. And so when they looked at the rate of clearance, so these spaghetti plots where each line here is a patient, and so basically looking at their quantitative culture counts in their CSF. And so as you can kind of basically see, these are all very similar. And so when you look on the standard sort of 14 days of therapy, the rate of clearance was 0.41, so this is sort of log 10 CFU change per milliliter of CSF per day, and was basically not statistically different from the one-time dose of ambisome. And so this was a phase 2 study. It was recently published in July in CID. and sort of form the backbone of moving forward, basically more traditional versus the single dose therapy. And so the study design is as such. The trial has a target of 850, so it's a non-inferiority study design. And there's 6 sites that are enrolling, and so the sites include Cape Town and Gaborone in Botswana, Harare in Zimbabwe, Lilongwe and Blantyre in Malawi, and then 2 sites in Uganda in Kampala and Mbarara in Uganda. So far, they've enrolled 27 patients. So somewhat on the slower side, but a number of the sites have just come on board for their site initiation visits and open for enrollment. So that should rapidly pick up. And so that is, it's a non-inferiority design, but potentially very nice for resource-limited areas where if you could do a single one-time infusion of amphotericin, that would be sort of a huge aspect. Coupled with that, Unitaid has negotiated with Gilead to reduce the price for low and middle income countries for their Ambizone product, and so instead of $144 per vial, it would be $16.25 per vial, and so then you're really talking, about $160 for therapy for the amphotericin, and that's basically about the same price as amphotericin deoxycholate, which is about $12 per vial, and so about $144 for a treatment course of amphotericin deoxycholate. And if I had a choice of 14 days of deoxycholate or one-time liposomal ampho, I think I definitely would prefer the one-time dose myself. So that's the current. And so the future, there's basically 2 other studies that are in the works that have funding that are going to happen as opposed to we would like to happen, but should be funded. And so the first is basically that same concept with liposomal ampho given in the asymptomatic CREG positive group with sort of the standard of care fluconazole backbone. And then the second is an oral amphotericin product, and so I'll go through these briefly. And so just for a little bit of background, when you looked at the asymptomatic cryptococcal antigen sort of positive group, these people that sort of come in, they're detected early, so if you do nothing, they'll eventually go on to develop meningitis and or die. But if you give them fluconazole monotherapy, they do much better. And so, but still there's about a 25% failure, 25 to 30% failure rate of either developing meningitis and death. And so this is basically basically correlates with the burden of how much fungus is there at present. And so for those with sort of low titers, medium titers, or high, these are titers in plasma, basically you have sort of better versus worse outcomes. And so you're looking at sort of 85% survival rate through 6 months among those with low titer rates, and that's basically about the same as a population that has a CD4 count less than 100 versus your high titer group. Even though these people are asymptomatic, a lot of these people had lumbar punctures to document that their CSF was negative by cryptococcal antigen as well as by culture. They still do quite poorly, and so their survival is 40%, and so that's really almost worse than people with meningitis. And so clearly the people with high titers do not, fluconazole monotherapy, while it's perhaps beneficial from 100% rate of death, 60% mortality in these sort of populations that start out relatively asymptomatic without CNS overt disease, really do need to be treated more aggressively and treated like they do have a disseminated infection. And so one of the things with the high titer group is basically, even though their CSF may be negative, they likely do have crypto in their brain. And so just because their meninges and their CSF is clear, you have to sort of treat them as if they actually have disseminated disease and more aggressive therapy. And so what to do, I think this provides some opportunities for future trials, and certainly if you can improve upon a 25% failure rate with a better second agent, that is certainly a kind of a low bar. One of the other things that pops up, which physicians aren't as knowledgeable about or just because they haven't seen a lot of this, is that when people sort of unmask their meningitis after they start their HIV therapy, oftentimes this iris reaction can be CSF CREG negative and culture negative. And so they may just have sort of inflammation going on and having sort of clinical meningitis, but if you look, basically you don't necessarily find this. And so this is probably oftentimes missed. So unless you know they're cryptococcal antigen positive in blood, they come in with this aseptic meningitis and they don't do very well. And so they have a fairly high mortality rate. And so among this unmasked group, the mortality rate's up to 70% even with amphotericin therapy. And so that's sort of a problematic group. And we've done PCR, and we've looked for other pathogens, we've looked for TB, and so they just have sort of this iris phenomenon. So for the single-dose liposomal trial, ACACIA, I'm not sure exactly how the acronym works out. There's a lot of A's and C's in there, but basically this is led by Radha Rajasingham among our Minnesota group in collaboration with David Maya in Uganda, and basically looking at a 100-person sort of phase 2 pilot study to sort of see proof of concept, where basically people are randomized either fluconazole or fluconazole plus the single dose of liposomal ampho. And basically looking at some safety monitoring, we'll follow for 6 months outcomes. So fairly straightforward concept. And then lastly, sort of oral amphotericin B. Maybe I should put a question mark there. So it's actually oral and it's absorbed. And so I think William Hope's going to talk a little bit more about this, but basically this concept of encocleation is kind of just a delivery vehicle where you can stick whatever XYZ drug that's not normally absorbed inside of a soy lipoprotein, and basically it gets taken up and sort of has a relatively sort of a high intracellular delivery into macrophages and monocytes. And so this concept, it looks great once again in mice. So Peter Williamson's data from intramural NIH, the two groups of note. So the standard sort of injectable amphotericin with 5-FC versus this encocleated ampho with 5-FC, very similar sort of outcomes in his mouse model. And so once again, looks fairly good in mice, and he's replicated this in a couple different variations of his model, but looks fairly good in an animal model. And so we're basically doing sort of a phase 1 study, just trying to look and push the dose. So they did a phase 2 trial in candidiasis and vaginal candidiasis, and it didn't work so great as compared to fluconazole. And the question is their dose correct? And so they've used just basically single dose where they've looked at 200 milligrams, 400 milligrams, and 800 milligrams. And as you sort of push the dose as a single dose, you get more GI side effects, likely due to just unabsorbed product. And so sort of 400 milligrams is sort of the max single one-time dose, but they haven't really looked at, can you give multiple doses per day, and does that increase your GI tolerability? And so we're going to basically do that, looking at 1, 1.5, and 2 grams a day with divided dosing to see what's the maximal dose that you can tolerate. So we hypothesize that you should be able to push the dose up quite a bit. And so basically, this then moving the max tolerated dose forward into a phase 2 trial of basically different durations of the oral amphotericin before going to a rescue IV therapy, and then assessing the CSF clearance. And so this is kind of a different way to format it, where basically the first stage, the first 20 people will get sort of 4 days of the drug. They'll get LPs on day 1, day 3, and day 5, and then they'll be switched to IV therapy. The second group will go a little bit longer, get some more LPs along the way to document the rate of clearance before switching to IV therapy, and then sort of the last group sort of longer. And if successful, this will sort of go on to then sort of just oral therapy alone. So that's sort of the trial design for this study. So of sort of the new and novel agents, basically there's Sertraline Tamoxifen, which I think are going to basically are dead and not going to move forward. But I think the more exciting thing is that, and what William Hope is going to talk about, is that there are some new things in the pipeline. So the Viamet drug, Amplex, the oral amphotericin, neurophoresis, there's a number of new agents and new concepts emerging. And I will stop there and invite William to take up from here. And lastly, to acknowledge, we have a great team we work with in Uganda. There's a couple people, the people in red, I think they're all over in the corner. So Josh Ryan, Masa Bassi, and Caleb Skipper, and so they're parts of our team who have done a lot of patients. And I think Masa probably has seen more crypto patients than probably anyone in the U.S. Have seen probably 500 crypto patients in the last 3 years. So lots of great clinical experience, and they would be great to meet all of you. So please say hello to them. So I'll stop there. And any questions? If you have, we're going to talk more about clinical trials during sort of the session, and so future clinical trials and other things. So if you don't have questions, that's fine, and we can stay on time and have William Hope start. Yes, please.
Thank you very much for a revealing series of studies. And one feature that it does reveal, I think, is to add the murine models at least in those studies, to the long litany that could fill blackboards of the unpredictability. And I would ask, why, given the powerful predictability of the cryptococcal meningitis rabbit model, were given all the massive resources that are used in these clinical trials and comparatively minimal resources for the rabbit model, why were sertraline and tamoxifen not studied there prior to going into the trials?
Good question. So I think William's probably going to touch on that as well. That I think looking at different models, and I think the rabbit model certainly has been quite quite good over the years. And so I don't do a rabbit model, part of the issue. And so, I mean, the resources to do animal studies are not trivial, and so, but at the same time, yeah, that's a good question. So I think I have learned something certainly. All right. Otherwise, I'll invite William. So William Hope is our next speaker.